Maria Luis, good morning, America, and good evening, Armenia. Today, I'm going to provide a sort of a talk which intertwines multiple sclerosis, demyelinating disease, some mimics, and brain tumors. So just stay with me as we go through this. And I want to start just with some of the underlying histology of the white matter. And in this beautiful rendition of the white matter, you can see the wrapping of the myelin sheath. Myelin sheath is a fatty structure that is the target of demyelinating disease, whatever the cause, although we're going to focus today on multiple sclerosis. The one feature of the myelin, which is important to recognize as we talk about PML, is the fact that the oligodendrocyte, and you can see these foot processes project to the myelin. This is, in a way, you can think of it as the shepherd and the sheep, or the farmer and his crop. The oligodendrocytes nurture the myelin sheath, and so any injury to the oligodendrocytes will result in a secondary demyelination. This is, of course, larger scale autopsy specimens from a patient, and you can see clearly the white matter, and aptly named, here in contrast with the cortex, and here you see the fine structure of the hippocampus as well in this coronal section through the temporal lobe, and here both hemispheres here at the level of the mammillary bodies, again demonstrating the sharp demarcation between the white matter and the gray matter. Now, this is a case that I think shows what we would consider the typical features of demyelinating disease in the brain. The age of the patient is important to consider. But the features that I want to accentuate here are the fact that the lesions parallel the border of the ventricles and are here perpendicular to the margin of the ventricle. These are so-called Dawson's fingers. These are projections along the veins, parallel to the veins, which gave rise to a whole theory about a venous cause of MS at one point in time. The other feature I want you to notice is that the lesions are fairly well seen on this T1 weighted MP-RAGE section. And I think that is one of the features that will help you distinguish this from age-related white matter change, in addition to involvement of the corpus callosum. In the aging patients, it is not infrequent, as you know, to see scattered white matter lesions, but specific involvement of the corpus callosum is unusual. The other thing to notice is that depending on the age of the patient, you may see some features of atrophy with widening of the cortical sulci due to volume loss as a result of the demyelinating disease. So again, just to highlight some of these typical imaging features, these are lesions involving the corpus callosum and white matter lesions perpendicular to the ventricular margin. The lesions are usually asymmetric. There can be enhancement with active disease, although the enhancement is typically peripheral, although not always. And you frequently will see supra and infratentorial involvement. With regard to whether we're looking for white matter disease or gray matter disease, of course, we're looking almost exclusively at white matter involvement. However, some cases of MS will have some gray matter involvement, and depending on the resolution of your imaging and the quality of your imaging, you can see some gray matter involvement. But this relative sparing of the gray matter accounts for the clinical presentation of MS, which rarely is one of seizures. We talked about that in a previous talk, that seizures are generally from a cortical epileptogenic focus. This is a set of criteria that was a consensus, and features that, and I sort of often embody these in my report. So rather than say there's 7 periventricular lesions or there's 12 periventricular lesions, the important discriminator is, do you see 3 or more periventricular lesions? Do you see 1 or greater infratentorial lesions? Spinal cord lesion, or and this is sort of, you can lump these together as a single category. Here they talk about an optic nerve lesion and a cortical or juxtacortical lesions. Now, with age-related white matter change, you will see a lot of cortical and juxtacortical lesions, or specifically juxtacortical. But you rarely will see infratentorial lesions, with the exception of involvement of the pons. But it's these periventricular lesions that frequently are discriminators. There's one feature that's not on this list, would be an enhancing lesion. So the presence here, they say, of 2 of these 5 areas involvement. But I think if we think about periventricular lesions, infratentorial lesions, juxtacortical lesions, and enhancing lesions, 3 of those 4 categories should allow you to make the diagnosis of MS on an imaging basis. Now, in terms of follow-up imaging, once the diagnosis is established, and of course, for a long time, the diagnosis of MS was felt to be a clinical diagnosis, although frequently it is now a diagnosis that incorporates the MRI findings. But follow-up imaging is considered part and parcel of the management of patients with demyelinating disease with the utilization of immunomodulating medications. And so the decision about the type of medication and dose of medication is based on the appearance of progression on imaging. And important to recognize that clinical follow-up is, of course, important, but measuring things like increasing fatigue or other neurologic findings can be difficult because of some expected variation from day to day. So the follow-up imaging with MR is critical for the clinicians making decisions about the patient's medication. Now, in terms of follow-up, it is the opinion of myself and many others that gadolinium is not necessary on every single follow-up scan. These are frequently young patients who are going to have regular imaging over the course of their lifetime. And there is some lingering thoughts about whether gadolinium is entirely safe in terms of repeated dosing, because we see the vestiges of the gadolinium on MR imaging. So personally, I think I would prefer to avoid gadolinium if possible. So what you can look for is change on the FLAIR scan and T2 weighted imaging. So if on follow-up there's no change in the appearance on the FLAIR and T2 weighted imaging, then gadolinium is not necessary, because it is extremely unusual to see enlargement of an existing lesion and that sort of thing. And so if you have stability on conventional imaging, I don't think you need gadolinium. The gadolinium is necessary for the establishment of acute disease, or sort of new plaques. But what we're really looking for is progression of existing plaques. And you can limit the follow-up to brain or cervical spine imaging, but I don't think that you need to do the entire spine on every patient, partly because of the time constraints and the low yield in seeing isolated progression in the thoracic spine. This is a paper we published some years ago. This with one of your Armenian colleagues, Dr. Davchin. We looked at a number of patients on follow-up imaging and could not find an instance of clear progression that required gadolinium that you couldn't establish on the non-contrast imaging. Now, this notion of follow-up brings up 2 important pitfalls that you need to be aware of. One is you can't rely on just T1 and T2 weighted imaging. Oftentimes the lesions are obscured on the T2 weighted imaging, so you need to incorporate some proton density technique or inversion recovery technique to increase the conspicuity of the spinal cord lesions. And flare, while very helpful in the periventricular compartment, it can be insensitive in the posterior fossa. And then finally, in patients with isolated cord lesions, while I think it is important to consider multiple sclerosis and demyelinating disease, and to get a complete study of the central nervous system, including brain and thoracic spine, it is possible to have cord involvement without brain imaging. This is a patient with a spinal cord lesion. You can see expansion of the cord, this sort of flame-like involvement of the cord. You'll notice it's in terms of longitudinal involvement, it's approximately 1 vertebral body, and it shows this quality of rim enhancement. So important to recognize that this appearance, while suggestive at first glance of a spinal cord tumor, this patient proved to have MS. And if you look on this was the brain imaging. I'm not going to show the entire scan, but there were no evidence of brain lesions in this patient. So again, only about 10% of patients will show that constellation of spinal cord involvement with the normal brain. But I think it's empowering to know that's a possibility if you see a patient with that set of findings. Now, the other thing I want to highlight here is this is a patient with, I think, a pretty good quality T2 weighted scan. Oftentimes, the T2 weighted scan is difficult to make a diagnosis of MS lesions because of this property of pulsations coming from the CSF. Usually, the phase encoding direction is anterior to posterior. Try to avoid craniocaudate phase encoding because you'll get actually many more artifacts across the spinal cord. Oftentimes, all you'll see if you do axial T2 weighted imaging is the lesion may be evident on the axial, but not on the sagittal, which is not confidence inspiring. This patient did have evidence of MS lesions in the brain, and there are some features that I think you should recognize at the outset. If your first thought when you see an enhancing lesion like this is to think of a brain tumor or a metastatic disease, that sort of thing, notice that there's very little mass effect here. See the normal contour of the ventricle, even with this enhancing lesion right next to it. So again, you want to think about the underlying pathophysiology in these patients. In the case of a metastatic lesion, you have a patient who has, in theory, a normal volume of the brain where you're adding something to the volume of the brain. That is the growth of the metastatic tumor cells, which are going to be space occupying. In the case of demyelinating disease, you are looking at an injury to the existing white matter. And so oftentimes the degree of mass effect is not proportional to the amount of brain that's involved. Now, in this image, this is a proton density image. Now, again, the downside of proton density image is that we see that the CSF and the spinal cord are similar in signal. But again, we're not looking for the contour of the spinal cord, which you can see well on the T2 weighted scan. We're looking for intrinsic signal abnormalities in the spinal cord. And so this proves to be a real lesion that is better demonstrated on the proton density. So in terms of protocoling these patients, I think you should incorporate one of the more advanced techniques with inversion recovery or proton density when you're looking for lesions in the spinal cord. But of course, FLAIR imaging is very helpful in looking in the periventricular region. Here you see sharply defined lesions that are adjacent to the temporal horn. I don't think this has really been well published, but it is part of my understanding and my experience that if you see lesions lateral to the temporal horns and you're considering whether you're looking at age-related white matter change or demyelinating disease in a patient of 40 years of age or older, you want to favor demyelinating disease because this is unusual to see lesions in this location as part of white matter change of aging. The other feature that I think should strongly favor the diagnosis of MS is the presence of lesions in the middle cerebellar peduncle. It is very unusual to see unilateral middle cerebellar peduncle involvement without any other cerebellar involvement in other diseases besides MS. This is, of course, a patient with MS showing you this periventricular involvement. Now, if we look at this FLAIR scan, you'll notice, as always, we have issues with unsuppressed CSF here in the fourth ventricle, here in the prepontine cistern. Now, is this a real lesion or not? I think it would be difficult to feel confident about that on FLAIR study. And yet here on the T2 weighted scan, you can see unequivocally there is a lesion in the middle cerebellar peduncle. And so this lesion, which we can now say is there with some confidence, will strongly favor the diagnosis of MS. So don't limit yourself to FLAIR imaging. When you're looking at the brain, you need to look at both T2 weighted imaging and FLAIR imaging if you're going to get an accurate assessment of involvement both above and below the tentorium. And this is a paper from 1997, so this has been well known that this limitation of poor detection of posterior fossa lesions and the idea that FLAIR cannot replace, here they say conventional spin echo, but now we use fast spin echo as part of the evaluation of these patients. Now, this is only part of the list of things to consider when patients present with first-time symptoms. Depending on the patient's age, it can be quite difficult to make these distinctions. And so some of the things we're going to consider in diagnosis are going to be just age-related white matter changes. This entity, which I think has, at least in my experience, has received more attention recently, these MOG antibody syndromes and this ADEM, or acute disseminated encephalomyelitis, may be part of this MOG spectrum. These patients will have what will oftentimes be described as atypical MS imaging. Neoplasm should be considered, and we'll get into that in some length. PRESS, PML, Susak syndrome, and then these cortical dysplasia, tuberous sclerosis. Now, the reason I'm saying these are MS mimics is because the imaging can be similar. But again, for you as clinicians, you have to keep in mind that the clinical history is essential. The clinical history should help you discriminate Susak syndrome from MS, even though the imaging is similar, because these patients often present with optic symptoms first and may be referred from ophthalmology. PML, these are usually patients who are immune compromised. PRESS, these are patients who are receiving medications like cyclosporin or other medications which can lead to elevated blood pressures. The MOG antibody cases can often be separated out with laboratory testing of CSF. So again, there are multiple features here that will allow you to make these distinctions, but I want you to be aware of this range of appearances so that we don't report these other diseases as possible MS. This is a case of multiple white matter lesions, and this is an elderly patient. You can see with extensive periventricular involvement, corpus callosum involvement, all of these white matter lesions, but this patient does not have MS. Notice the clean appearance of the lateral border of the temporal horns. This is typical with age-related change. So in spite of all of those changes that we see on the other sections, the lateral border of the temporal horns look actually pretty good. So this is age-related change. Remember, these pontine changes are also quite common with aging and does not put this into a different category of disease. So this is age-related change. I would prefer, in terms of terminology, to try to avoid calling this a disease. Aging is not a disease, and it's part of the evolution of the brain. Think of it as like you're a dermatologist. You're not going to report every age, age spot on the skin. So these age-related changes are probably a conglomerate of areas of ischemia, gliosis, areas of myelin pallor. They're probably not all the same thing. And so I generally put them in that basket rather than calling it microvascular disease or some hypoperfusion syndrome, which implies there is a clear vascular cause or underlying vascular abnormality. Now, is this MS? We have extensive white matter changes here, but the important thing to recognize in this case is the symmetry. MS is rarely this symmetric. So we have symmetric involvement here. You can see in posterior limb of the internal capsule. You'll notice there is a diffusion abnormality in this patient. And while the middle cerebellar peduncle is involved, it's involved symmetrically and bilaterally in the so-called claw appearance. And this is an unfortunate case of heroin complication from inhaled heroin. It's called chasing the dragon, but this is unfortunately a typical appearance for that particular phenomenon. We saw in one of the lectures previously bilateral hippocampal involvement in Dr. Mohan's talk, and so drug effect should be considered in your differential of white matter disease. And again, remember that other metabolic insults like hypoglycemia, hypoxia can also give you white matter involvement, but again, usually symmetric. Now, here's a patient with an abnormality of the corpus callosum. And there's some other lesions too, but notice they all have restricted diffusion and we have involvement of almost the entire corpus callosum. This would be an unusual appearance for multiple sclerosis. And assuming this is an adult patient, which it is, one of the things you have to consider is ischemia and drug effect. The flagell can give you involvement of the corpus callosum as a drug effect, often with cerebellar involvement. But this is a patient who you can see has bilateral carotid disease, has hypoperfusion probably of the anterior cerebral arteries since all of the flow is coming retrograde through the posterior communicators from this basilar injection. You can see this unusual involvement or filling of the anterior circulation from the posterior circulation. So usually in patients with corpus callosum infarcts and white matter infarcts, but more specifically callosal infarcts, they tend to have quite evident vascular disease. Here's another patient with white matter involvement, but you notice there's bilateral basal ganglia involvement. So again, this pattern of involvement would be unusual for multiple sclerosis, and basal ganglia involvement is not common in MS. However, if no other explanation can be found, and this one proved to be PRESS based on the clinical history, but if you have basal ganglia involvement and white matter involvement, then you should be thinking about this MOG antibody syndrome, because basal ganglia involvement does occur in that and rarely occurs in multiple sclerosis. Here's a patient with 25-year-old, and you can see there's a lesion in the middle cerebellar peduncle. There's a large white matter lesion here. You can see there's some T1 prolongation on the T1 weighted scan. There might be a little mass effect on the lateral border of the ventricle. While there is enhancement, notice that it is all peripheral, right? So we have unilateral middle cerebellar peduncle involvement. We have these large lesions, and most of the lesions are enhancing. So when you see a pattern like this, this is a case where you should think about ADEM, acute disseminated encephalomyelitis. And this is what the patient looked a week later with some treatment with steroids, and this patient over time, these white matter lesions largely resolved. There was actually a little residual, but they largely resolved. So this case, when it came in, was, it's one of these cases that seems puzzling until you sort of put it all together and makes sense as being one of the presentations of demyelinating disease. Here's another patient we saw actually last year, 25-year-old with has a history of visual symptoms and was carried clinically as an atypical MS case and came in with some new symptoms. Now notice the symmetry of involvement. Here you see subcortical involvement, this kind of paired subcortical involvement in the frontal lobes, and somewhat unusual in that there's relative sparing of the ventricular border. You don't see any definite callosal lesions, maybe a dot here. But this is what the patient looked like 4 years previously. And you can see, again, some of these lesions were here, but many lesions were enhancing, but not peripherally, more solid. And so based on the sort of slow progression in this case and the periodicity, the feeling was this was a variation of demyelinating disease, and testing was done for these MOG antibodies, and that's what this proved to be. I thought we would get to that. We'll get to that in, but this is another patient with these, again, white matter lesion here that's enhancing, other enhancing lesions here, enhancing lesion in the cervical cord. This was diagnosed, this was an ADEM case, again, acute disseminated encephalomyelitis. And I just wanted to put up this one article as a nice review of basically how the imaging of this MOG antibiotic disease differs from MS. Some of the features, I'm not going to go through all of these things, is the spinal cord lesions tend to be longer. There can be basal ganglia involvement, and this sense that there may be this overlap between acute disseminated encephalomyelitis and this more scattered pattern in MOG antibiotic disease. So again, if you think you're looking at a patient that is atypical for MS, particularly if it's atypical both clinically and from an imaging point of view, I think you should list this in your differential because specific testing needs to be done to establish the diagnosis. Now, this is a 29-year-old presents with new weakness. And so here there's no question about the abnormalities. We have this lesion here and here. There is some restricted diffusion peripherally, and you can see the lesions are very sharply defined. There is probably a little bit of mass effect here. This is the CT scan of the patient. Actually, it started out as a stroke alert. CT was done first, followed by MR. So before you spin off into any sort of differential about a case like this and trying to establish a diagnosis of, say, multicentric glioma and such, you want to at least consider demyelinating disease. And I think that this patient actually had an MR spectroscopy. And again, if you're familiar with spectroscopy, somewhere here, like you'll see just as we remember the numbering goes 1, 2, 3, 4 in terms of shift. This is going to be your lactate peak. The NAA is diminished and the choline is elevated. So most people, I think, would look at that and say this is suggestive of a neoplasm. And I want to show this to you because this would be a pitfall, but knowledge is power. And so be aware that in the cases of these acute demyelinating lesions, MR spectroscopy can be misleading, that all we're really seeing is the breakdown of the myelin with the choline elevation. This is not due to cellular turnover, and this is tumefactive demyelination. Here's another patient. You can see this discrete lesion, largely subcortical, no definite cortical involvement. Peripheral pattern of enhancement, also incomplete ring of enhancement. And here's what it looks like on the CT scan. Notice that it's uniformly low attenuation. Going back to this other case, notice the lesions were uniformly low attenuation. This proves to be a helpful discriminating feature between tumefactive demyelination and brain tumors, is that if we think about tumors like lymphoma, high-grade gliomas. These are usually highly cellular tumors that often can be of higher attenuation than the brain on the CT scan. So when you have these lesions that are uniformly low attenuation on CT, no high attenuation centrally, you want to think about tumefactive demyelination, which both of these cases are. So again, this was a paper some time ago in radiology, talks about using CT to discriminate between glioma and central CNS lymphoma. So obviously not a simple problem that they would even be writing about it. So what features can we look for in discriminating tumefactive MS from brain tumors? So as I just pointed out, CT can be helpful. I find MR perfusion can be helpful if you have access to that. What we expect to see with an MS lesion is low relative cerebral blood volume as compared with even lymphoma, but especially high-grade gliomas, which tend to have elevated cerebral blood volumes. The enhancement is usually ring-like, although I've seen at least one case with central enhancement that went to biopsy unnecessarily. There is this disproportion in terms of mass effect, that the lesion is larger than you would expect for the amount of mass effect. I pointed out MR spectroscopy is not reliable, and I don't really know what to suggest in these cases, because we know MR spectroscopy is not reliable in low-grade neoplasms, and if it's not reliable in when it's positive, and then I don't know what the point really is of doing it. And I wouldn't recommend using spectroscopy. And again, when you're in doubt, just follow up in 6 to 8 weeks. It's better to delay the diagnosis of a brain tumor by a month or two, which really will not substantially affect prognosis, rather than to biopsy an MS lesion. Now, again, I'm showing you my own errors. This was a patient, and you can see is actually in a head frame that was headed for the surgical suite. And this was a young patient, had a white matter lesion, not a lot of mass effect here, completely isolated to the white matter, and looked to me like this could have been tumefactive demyelination. So we called the surgeons up before the patient got to the OR, and we said, you know, we're not sure this is a neoplasm. This is before we had perfusion imaging. And they took the frame off and decided to bring the patient back. This is what the patient looked like a few months later. And you can see that the lesion has expanded, and now there's this central enhancement within it. And this proved to be an anaplastic astrocytoma. So I don't pretend like the distinction between tumefactive MS and neoplasm is easy. But I think it's fair to say that you should be thinking about tumefactive MS, because it's, as far as I'm concerned, one of the values that we provide as neuroradiologists and radiologists is to avoid a biopsy when it's not necessary. This is a case that was from actually that Med Mastery course that I think nicely shows the peripheral rim enhancement between this lesion. This lesion actually extended to the cortex, but again, notice it's of very low attenuation on the CT scan, and again, not much mass effect on the ventricular margin here. Now let's look at this patient. So again, we see there's asymmetric white matter involvement. There seems to be a lot of subcortical involvement, however, with very little periventricular involvement. And notice how for the extent of these lesions, how very little mass effect they are. You see the way it sort of insinuates its way through the subcortical white matter and U fibers. So the important question in a patient like this is the patient immune compromised? And if the answer is yes, then this could be due to prior transplant, HIV status. This is a patient with PML. So what are the features of PML? You want to consider, again, patients who are immune compromised. This is secondary demyelination from involvement of the oligodendrocytes. But the main features of PML is, and unlike tumefactive MS, is there should be, in most cases, no enhancement. Although that is not, oddly enough, that is not a uniform factor that you can rely on. I remember I worked at Dartmouth for a number of years. I never saw a case of enhancing PML, but then I went to Penn for a number of years and I saw a number of cases of enhancing PML. So I'm not really quite sure how to account for that difference. I don't think the agents change that much, but I think it's one of those imaging features that you can't rely on confidently. But I do think it's fair to say that the relatively low mass effect is reliable, and you want to think about that in patients who are immune compromised. This is an unusual disease. I can't say I've seen many cases of this over my career, but just this was a paper from 2004, talks about this disorder. It's called Susac syndrome. It's actually, that's not an acronym. That's actually a name for the individual who described it. And you can see it forms, it's reported to form these round lesions in the corpus callosum. But the important thing here is the clinical symptoms. These patients can present, they'll often have hearing loss, but oftentimes they present with retinal arteriolar occlusion. So the imaging features in this should be correlated with the clinical history before attempting to establish that diagnosis. But be aware, it is a mimic in appearance for multiple sclerosis. Other white matter entities you want to consider. Here you can see this white matter lesion, which may extend to the ventricular margin, but you notice the thick appearance of the cortex here. This is the white matter change that goes along with cortical dysplasia. This is a Taylor's type dysplasia. This is another one that gives you a multiple white matter lesions that, again, at first glance might be confused with multiple sclerosis. But if you look carefully, there are these areas of signal dropout in the ventricular margin. And so this is the white matter change adjacent to these cortical tubers and tuberous sclerosis. And these would be the calcified subependymal nodules. So again, don't get sort of tunnel vision about the white matter lesions. There are many other disorders that will give you scattered areas of white matter disease. So in terms of the whole distinction between MS and brain tumors and categorizing brain tumors in terms of what gets biopsied and what doesn't, before you start thinking about brain tumors, you want to make sure there really is mass effect. If there's no mass effect, you're back in that category of PML and tumefactive MS. You can, we've seen, MR and CT can often be used to establish the diagnosis and also helpful to confirm that you're looking in the correct compartment, that is categorizing the lesions as being either intraaxial or extraaxial. Obviously, it's extraaxial, you're not dealing with demyelinating disease. And then you want to consider, as you look at each case, could I be looking at tumefactive MS, giant perivascular spaces, and lymphoma, and so on, all lesions that may require a biopsy rather than resection. So this is a typical giant perivascular space. It lies in the putamen. You can see that it has no signal on the FLAIR scan. That is, the fluid is completely suppressed and looks just like the CSF in the subarachnoid space. There can be a little bit of T2 prolongation adjacent to perivascular spaces that doesn't really change the diagnosis. And of course, it does. T2 weighted image, again, these are filled with CSF. Now, this is a specific type of giant perivascular space that tends to be seen in the temporal tip, which has a disproportionate amount of T2 prolongation for reasons that are not entirely clear to me. But this pattern, I think, is troublesome. And I know at least one of these cases I saw went to biopsy because there was a concern it was the low-grade neoplasm. So just be aware of that. If you see what looks like a perivascular space in other ways, that is, it shows no enhancement, suppresses on FLAIR imaging, in spite of this T2 prolongation, if it's in the temporal tip, you want to consider this variation. Now, these perivascular spaces can become tumefactive, that is, they resemble tumors. Here you can see multiple lesions here, sort of snaking out along the posterior limb of the internal capsule, a little bit of T2 prolongation peripherally. There's no enhancement. So these are tumefactive perivascular spaces, which usually only require follow-up imaging. No treatment is necessary, and even in some cases may cause some mass effect. I know one patient we had, they had these in the midbrain that required shunting, but don't require any treatment beyond that. Now, this is a pattern of disease you should recognize. These are lesions in the periventricular region, sort of tracing here along the optic projections, but this periventricular enhancement, often in the subependymal compartment, is very suggestive of lymphoma, CNS lymphoma. CNS lymphoma is a disorder that usually requires only a biopsy, if anything, and doesn't require resection. They respond in most cases to treatment once the diagnosis is established. They have this quality of having high attenuation on the CT imaging. They often enhance, but uniformly, not peripherally, as we saw with the demyelinating disease. And here you can see on the ADC map, they have some qualities of restricted diffusion. If you look at this lesion that's along this ventricular border here, it shows restricted diffusion quite well on the ADC map. These are all typical features of CNS lymphoma. Here's a 24-year-old with a new seizure. Again, ring-enhancing lesion in the white matter. Before you leap at the diagnosis of neoplasm, this one actually proved to be MS. Even though I told you it's unusual for MS to present with seizures, it was the case in this patient. And when I say it's rare, it's probably on the order of 1 to 5%, which is not very common. Another pitfall that you need to be aware of is that I'm not sure in Armenia whether it's common, but it's certainly common here in a lot of cases where patients will have a low-grade neoplasms, for example, a meningioma and whatever, depending on the concern of the patient and the clinician, they may get regular imaging. Now, if that imaging is done on the order of every 6 months to a year, and the patient has a slow-growing tumor, one of the problems that occurs is the reader will get complacent about comparing the scans, because oftentimes it's very difficult to assess volume just by looking at cross-sectional imaging. Excuse me. Here you can see this lesion in 2006. Here's 2007 to 2008. So again, it doesn't look much different. Here's 2008 to 2009. And I'm showing this case because every follow-up scan was read as no change, no change, no change, no change. Now let's look at 2006 to 2009. Now here, when we look at the earliest scan, we see, yes, there is more volume here. I don't need a 3D rendering to tell me that that tumor has grown over time. So be aware of that pitfall of imaging. And I think in terms of your practice, what I do is I just go back on all of these slow growing tumors that are being followed, go back to the original scan and look for any change. If you see change between the first scan and the most recent scan, then you have to ask yourself, did the change occur recently? So the idea is that a tumor that has been stable for a long period of time and perhaps de-differentiated and now is growing quickly, or is it growing 10% every year, which is very difficult to assess visually, and that we just appreciate the change cumulatively over time. So again, just make that part of your practice, looking at follow-up of brain tumors. So again, as we look at cases, decide if we see mass effect. You want to determine, if possible, what compartment it lies in. Is it intraaxial or extraaxial? And could we be looking at something that's not a neoplasm, like cavernoma, an abscess, lymphoma, MS, and so on. So we look at this case. This is a 50-year-old. She was, I think, a stroke alert, came in weakness. And you can see she has this lesion, goes out into the cortex, shaggy, enhancing rim margin. Now, at this age, I would not lead with tumefactive MS. I think usually, in my experience, we tend to see it in younger patients. And so here's the diffusion scan. Notice it does not have restricted diffusion uniformly in the center, which is what you would expect to see with a brain abscess. So this proved to be a glioblastoma. And again, this high signal intensity on the diffusion weighted scan reflecting restricted diffusion is due to the high cellularity of this tumor, similar to lymphoma. Now, could this be lymphoma? Again, it would be very unusual for lymphoma to have this pattern of peripheral enhancement. They tend to be more centrally enhancing. So we've ticked off why we don't think that this is tumefactive MS. There's too much mass effect. The patient's age is wrong. The pattern of enhancement is too wide and too shaggy. We've sort of gone through why we think this is not lymphoma. There's no reason we're going to concern about other vascular lesions, so on. We don't think it's an abscess. And so that puts you in the right category, even though we may not be able to make the histologic diagnosis in this case. We can direct the management of the patient to the correct course, and that biopsy would be indicated, biopsy or resection. I show this in contrast to this case here. You can see this lesion has a relatively dark margin on the T2 weighted scan, quite a bit of T2 prolongation, a lot of mass effect as a result of all this edema, likely vasogenic edema. Notice that the central portion of the lesion is uniformly high signal intensity, even into these little subtle areas here, these little very fine areas of high signal intensity on the diffusion scan that shows marked low signal intensity on the ADC map. This is a typical appearance of a brain abscess. So again, showing you the difference between the way diffusion looks in cases of neoplasm, high-grade neoplasm, and brain abscess. Here we see a low attenuation lesion in the cerebellum. Again, I just told you that low attenuation is common in cases of demyelinating disease. However, after administration of contrast in this patient, you can see there's an enhancing nodule, and nodule enhancement is not expected in patients with demyelinating disease. So we're going to take that off the table, and we want to favor neoplasm. In this case, this is a hemangioblastoma. Here we have a large lesion involving the white matter of the right hemisphere, probably some cortical involvement in here, but again, you lose the gray-white junction here. Notice that there's almost no enhancement of this lesion. And this is an oligodendroglioma. Now, how can you distinguish that from an MS lesion? Well, as I say, usually the tumefactive MS cases have some quality of peripheral enhancement unless they've already been pretreated with steroids. But again, you could argue that in some ways it resembles an MS lesion because there is a lesion that's much larger than you would expect for the amount of mass effect on the ventricle. And we're not 100% sure about the cortical involvement here. But as I say, in this case, the absence of enhancement does argue against the notion that this would be tumefactive MS. You could step back from the case and say, I don't know if I could feel comfortable making that diagnosis on this one scan. And that's fine. If you have any question, just repeat the scan in about 2 months. Because the MS lesions, there should be some regression of the acute inflammatory changes with an MS lesion over the course of 2 months, whereas with the neoplasms, particularly low-grade neoplasm, you expect it to look about the same in 2 months' time. This lesion, I think I just want to show to you because it highlights this difficulty sometimes in establishing compartment. This looks like it's intraaxial on this enhanced MP range. Here again, it looks like it's intraaxial, but when you look at it in the coronal view, you see the broad dural attachment and actually a little bit of hyperostosis of the inner table of the skull. This patient's lesion is uniformly enhancing. This patient had a lot of mass effect with very few symptoms. This is typical for a meningioma. So again, make sure of your compartment before you even want to suggest a diagnosis. Here's another lesion, extraaxial in location. Notice that it's in the paracellular region. It shows a little bit of intrinsic signal on the FLAIR scan and abnormal appearance on the diffusion scan. And here it is on the ADC map. And so this is a typical appearance of an epidermoid. So again, the compartment, mass effect, quality of enhancement, these are all factors that you will have to consider. And then finally, there's this patient who has this lesion, which shows clearly has cortical involvement here, which takes you out of the category of demyelinating disease. And there's quite a bit of mass effect again with shift in the midline. But most importantly, unlike those other cases of tumefactive MS I showed you, there are actually calcifications in this lesion. And so this is typical for an oligodendroglioma. Now, this case I just want to show you because it has some, may present some difficulties at first glance. Here we can say that this, now again, we look at the patient's age, we're already not thinking about demyelinating disease. The pattern of diffusion, restricted diffusion is not that of an abscess. We again see this peripheral pattern of enhancement, which would argue against lymphoma. Again, quite a bit of T2 prolongation here, probably reflecting vasogenic edema. But I just wanted to show you, this is a patient where we did have MR perfusion, and notice the high signal intensity here, indicating an elevated relative cerebral blood volume when you compare it to the contralateral white matter. Now, that feature favors the diagnosis of glioblastoma, but there's another feature I want to show to you. Let's see, in this patient. Okay, this is another patient that has multiple lesions. This one's ring enhancement. This one's kind of rim enhancement. And I think you might consider the possibility here of metastatic disease. Oftentimes I see cases like this get reported out as could be multicentric glioma, could be metastatic disease. But I want to show you something that I don't think is widely known, but I think can be very helpful. You'll notice that the is abnormal here. And if you look carefully in this region on the enhanced scan, there's no enhancement there. So look for this whenever you're confronted by this question of metastatic disease versus multicentric glioma. If there's abnormal signal in the cortex that does not enhance, it favors the diagnosis of multicentric glioma. And the reason for that is that basically all cases of metastatic disease enhance, that the lesions all enhance because they do not have a blood-brain barrier. They have the vascularity of their primary tumor. So you won't expect to see this property of an intact blood-brain barrier, which is the case here, that glioblastomas can have some regional a variation in the quality of enhancement, as you know. So this heterogeneity of enhancement strongly favors glial tumor rather than metastatic disease. Well, we covered a lot of material there. I sort of took you through a tour through demyelinating disease, some of the mimics of demyelinating disease, and then finally into brain tumors, because as I say, oftentimes in cases of acute presentations of demyelinating disease, neoplasm will come up in the differential. And I wanted to give you some tools that you can use to try to sort that out. And again, when in doubt, assuming that there's not substantial mass effect and there's no reason to think it's a brain abscess, you usually have the luxury of time to try to make the distinction. Well, thanks for staying with me through all that. And again, at this point, I'd be happy to take any questions. No questions, nothing on the chat. All right, well.
Alex Ellen raised her hand.
Go ahead. Yeah, maybe just unmute your microphone.
Yeah, thank you, Professor. I have a question about the prognostic value of T1 hypointensity. Can you say some words about that?
Oh, in terms of, well, I mentioned that at the beginning, if that's what you're referring to. Yes, in patients with age-related white matter change, you rarely see the lesions well on T1 weighted imaging. So in this kind of category of disease, and I think I see that maybe not as much now as earlier in MR, that there would be patients with, let's say, 45 years old, 50 years old, multiple white matter lesions, but not a classic pattern of MS. And people will include in the differential, and they'll say, oh, these could be age-related changes, or ischemic changes, or MS, or vasculitis. I'd like you to avoid matter that are evident on FLAIR, but I can't find them on the T1 weighted imaging. I'm going to favor that those are age-related changes, because they're rarely seen on the T1 weighted scan.
Mm-hmm.
And just something to keep in mind is that early on with MR, when we were finding all these white matter lesions, the neuropathologists were saying, we're not sure what you're talking about, because you rarely see those lesions on autopsy. Unlike, the lesions, MS lesions, or actual true white matter infarcts. So these are lesions that are most conspicuous to radiologists, usually seen on FLAIR imaging. But as I say, if you have any question, the distribution of the lesions, the clinical history, and the conspicuity of white matter change should help you. Now, again, sometimes, you will see a little bit of T1 prolongation, but if they're sharply defined on, let's say, MP RAGE, then I think you want to move out of the category of these kind of non-specific white matter change and start asking about ischemia from, say, vasculitis, or underlying vascular risk factors and demyelinating disease.
Sorry, I mean, in cases when we have dark T1 signaling lesions with MS, multiple sclerosis, like when they call them black holes, does it carry a very bad prognosis for multiple sclerosis, or no?
I'm not aware of that having a strong prognostic value. I don't know if anyone else wants to comment, but I'm not aware of that.
Okay, thanks.
Yeah, thank you. It's a good question.
I have a question, dear Alex. Thank you for a great lecture.
Yeah, nice to hear your voice.
Yes, about JBM. Often we see a large lesion. A part of it has the typical contrast enhancement. The other part is like low-grade glioma. So when we see those kind of lesions, and we understand that we deal with JBM, can we think that the part which doesn't accumulate contrast is some low-grade part of it, or no? Theoretically.
I mean, there is this theory that there are two flavors of glioblastomas in adults. They call them de novo glioblastomas. Then these other tumors, which probably started out as low-grade neoplasms and worked their way through, grade 1, grade, and present only maybe later in their evolution. But I do think even in cases of de novo glioblastomas, you can have some heterogeneity of enhancement as well. So I'm not sure as I say, I'm not sure that it's enough to distinguish the two. I think your point's a good one. If you see a fairly large tumor where only a small amount of it enhances, then I think I would agree. I would favor that this was a de-differentiation of a lower grade neoplasm. But if I see, let's say, oftentimes these are ring enhancing necrotic tumors, let's say in the temporal lobe, and a portion of the cortex doesn't enhance, I don't think that's enough for me to say it was definitely a pre-existing low-grade neoplasm. I think that still could be a de novo glioblastoma.
Okay, and the other question about tumefactive demyelination. So, for example, if we deal with bullous concentric sclerosis, if we have large lesions, typical appearance, and can we think that after the attack, we'll have the same lesion in many years, the same lesion, same size, without contrast enhancement, or it can be changing and having more lesions, etc., etc. Do I understand correctly that it's not something continuing, it's just one attack, big lesions, and that's it?
That's my, well, I don't know about you can say confidently that there'll be no
No, I mean, what
later,
about your patients in your?
but yeah, usually the lesions regress in a course of certainly by 3 months, they regress.
Okay.
So they may, and I think they often leave some residual signal abnormality, but they do not look the same over time. But I don't have enough clinical experience or knowledge to say what the likely is that this will go on to sort of a progressive demyelination.
And
But I do think I think it is frequent that it is kind of one and done.
And if we think, if we talk about just MS, how often do you do delay contrast enhancement? And how many minutes do you wait till getting the images?
Yeah, we don't, I mean, at the last hospitals I worked at, we don't do delayed contrast anymore.
Why not?
I think it's, I guess, I mean, I think from a logistic point of view, I guess you could build in a delay. But I think it had to do with maybe the quality of imaging in early MR when, we were doing like higher doses and delayed contrast. But I think the feeling is that we see most of the lesions in, sort of the conventional protocol. But I don't think it's wrong to do it. I just would say that I'm not that familiar
What
with
I do at our proton clinic, we do, first of all, one image, for example, flare axial. After that, T1. After that, we do contrast. And after getting the contrast images, we do the other sequences. And at the end, we put a delay. So we don't lose a lot of time. We just add like one post-contrast.
No, I think that is an excellent approach, and there's no reason not to do it. I would say at Penn, I think we had so many scanners and so many technologists that I think they just kind of went to tried to simplify things as much as possible. But I think you're right in terms of maximizing conspicuity, and as long as you do it uniformly. The only risk would be that if the patient, goes from hospital to hospital, or they don't relate it one and another. But as long as you're doing it consistently, I think you're actually maximizing your chances of demonstrating disease.